Thank you very much, Dr. Sonagandhi, dear co-chairman, co-chairwomen, dear audience. Thank you for being in this hall early in the day, and I would just like to take a moment to congratulate the organizing committee for this wonderful meeting and to thank them for inviting me. I live in the third world, and I also practice in the third world. I go to 6 different African countries relatively regularly to perform mitral balloon valvuloplasties with different charity missions. Some of them are sponsored by my government, some of them are sponsored by different charities. This is one of our recent cases. In Cairo, we actually, in my hospital, where mitral balloon valvuloplasty, as you know, rheumatic heart disease is common in Egypt, is performed all the time. We have very few limits. My colleague Rida Bulata, who was here yesterday, kindly gave me those 2 slides of a case in which a pregnant woman who was very worried about X-ray because her fetus was such a precious baby, that he performed an echo-guided mitral balloon valvuloplasty without X-ray at all. I don't dare to do this, but this is one of his slides. This is his video showing his septostomy guided by echo. And this is his mitral balloon, his Inui balloon in the valve, looking by echo, and then of course he assesses the success and the presence of mitral regurgitation. Of course, he's ready to go into, this is in the cath lab, you can just put your foot on the switch if things happen. But anyway, so this is the kind of work we do in Cairo. But what about places like Ethiopia, which is one of the things I go? I go to Ethiopia with a Swedish mission. And this is data that they presented in Örebro in Sweden when they went back. In Ethiopia, where there's 1 doctor for 80,000 people and 1 cardiologist for each 8 million people. They compared that to their country, Sweden, where they have 1 cardiologist for every 9,000 people and 1 doctor for every 1,500 people. So this just shows you what you face in Africa. And the Swedish team, when they go, they actually come to Cairo first. They come to the National Heart Institute, and you do some mitral cases, because there are no cardiologists in Sweden who are trained to do mitral balloon valvuloplasty. They don't have rheumatic heart disease. They have 1 cardiologist from Pakistan, and when they asked him to do voluntary work in Africa, he said, I immigrated to Sweden. For economic prosperity. I don't really want to go back to the third world. So they come to Cairo, they pick me up, and we go to different African countries. This was a young woman who came with severe mitral stenosis. Her valve area was 0.6. She was extremely congested, she's super symptomatic, and she looked cachectic. This was a cath lab which had no transesophageal echo. Not only that, it had no pressure recording inside the cath lab. They had an intensive care pressure monitor, intensive care invasive pressure monitor. It had no power injector in the cath lab. It had no nurses or staff who had ever helped in a mitral case. We had gone to Cairo carrying our mitral balloons officially, and that was the only thing which was available, and Inui balloons taken from Cairo and standard echo machines. So you have to take a clinical decision. What are you going to do to this patient who's right in front of you, who's suffering, and you know that you have the technical skill, but the setup is dangerous. So anyway, we decided to go ahead with mitral balloon valvuloplasty. We put an X-ray apron under the patient, shield the baby, even though that's actually not very important. I'll show you in a minute. We didn't use any cine at all. Everything was done on fluoro. So all the cine angios I'm going to show you are actually from other patients, because nothing was stored in this one. This is when we are not using any form of echo guidance, no TEE, no eyes, nothing, we use septostomy using the old ways of septal stain, septal flush. We slide on the septum and we stain it with the needle of Rockenborough. And when you have the oblique line here, you see where the oblique line, you see the little stain near the tip of the needle, that is where you want to perforate your septum. If you're superior or inferior, you don't want to be there. This is going through the septum after staining it, and you can see the stain, which is totally benign. This is, you go in lateral to show exactly that you're heading posteriorly to the left atrium and you're not perforating anteriorly, you're not anywhere near the aorta. After you cross, you dilate your septum and use the Inouye wire, and of course you then perform sequential balloon dilatations. Again, this was a short woman, but we only had big balloons. So what do? You can't postpone the patient because you're going to be out of the country. So you take a big balloon against the label of the manufacturer, and you take it from inflation starting at 24 all the way up to 27 with a 28 balloon. This is how the balloon works. A lot of people in this room have probably done it. This is a valve as it dilates. We use a stepwise inflation. After each inflation, the operator, the single operator in the room who does this procedure, unscrubs and takes his handheld V-scan echo and echoes the patient to check the valve area opening and to check the degree of mitral regurgitation. That's exactly what I do in Africa because you're alone and there's no other choice. We've performed, by the way, in that mission, 32 cases which were reported in Africa PCR, all successful and all extremely symptomatic. This is a V-scan showing adequate mitral valve opening, showing some mitral regurgitation. It looks a little bit exaggerated by color here, but actually the next day it was just grade 1. The young woman with a very pliable valve and severe mitral stenosis with a mitral valve area of 0.6 and grade 1 mitral regurgitation, severe symptoms that worsened with pregnancy, and she was at the beginning of her 6 months. She had an uneventful mitral balloon valvuloplasty with successful outcome. Mitral valve area became 1.9 centimeters square. She had grade 2 mitral regurgitation, which improved. And I followed up on a subsequent visit, and she had a normal vaginal delivery of a healthy full-term baby. We know that the immediate and long-term outcomes of balloon mitral valvotomy in pregnancy are actually comparable to non-pregnant patients. This is a recent paper from India, which also has a lot of mitral and very, very experienced operators. And I was lucky to work on a voluntary mission in India. This was published in 2020. We also know from the International Atomic Energy Agency that can cardiac catheterization be performed on a pregnant patient? And the short answer is yes. There will be many situations where the benefit of performing the procedure is much greater than any small possible harm that might arise from the radiation exposure. There are many ways where you can minimize your radiation. Don't use cine, use fluoro. Stay away from the baby. Try to stay away, go to different projections away from the baby. Putting an apron, a lead apron on the table to cut down the primary beam actually has very little effects. But because it's so reassuring to the patient and to the nurses who are around, is recommended. Just to provide the use of the apron does not compromise, as far as it does not compromise your imaging. And that is what we did. Sometimes with pregnant patients with mitral stenosis, you're worried if they're too pregnant, you put them on a slightly side position to make sure that the inferior vena cava is not going to be occluded for long during the procedure. The mission was accomplished, really the transfer of knowledge. We've actually, several doctors from different African countries have come to Egypt, to the National Heart Institute, for mitral balloon valvuloplasty education. And more importantly, it was done to the patient who at that time needed that procedure. And I thank you very much for your patience.
Thank you, Dr. Hany.